Hello, I'm Dr. Tom King, and I'm the Medical Director at Immunovia. Today, I'd like to talk a bit about the current diagnostic landscape for pancreatic cancer. There are multiple situations in which a patient may present to be at risk for pancreatic cancer. They may have vague symptoms. They may be at high risk because of other family members developing that disease or a known genetic mutation that predisposes them to it. They may have imaging abnormalities within their pancreas that are detected either incidentally or for evaluation of other types of disease processes. Or they may have truly worrisome symptoms like jaundice and back pain that are very suggestive of pancreatic cancer. In these different kinds of clinical presentations, the prevalence or the frequency of individuals which actually have pancreatic cancer and not some other disease is going to increase from the left to the right of this slide. At the bottom, I've tried to show how the diagnostic process may work in these individuals. Some of them may simply have follow-up that may continue for a time, or they may be discharged if they're unconcerned about the changes that are present. They may undergo imaging, which is really a mainstay for the evaluation of pancreatic lesions because they're quite deep-seated within the body and difficult to examine otherwise. Endoscopic ultrasound, or EUS, is a more invasive technique in which a probe is placed through the esophagus into the duodenum, and then an ultrasound probe is applied directly to the pancreas to image it at close range. And the most invasive techniques of biopsy or fine needle aspiration, where a skinny needle is placed within the pancreas itself, either through the skin or through the use of endoscopic ultrasound and the probe within the duodenum. So those are kind of escalating methods of invasiveness, which ultimately will carry some degree of risk as well as cost and inconvenience. So how can we improve this process? Well, we feel that a blood-based biomarker test could really interact with this process in a number of different places and really assist in managing patients through to a diagnosis or to taking away their concerns that they actually have disease. So individuals with vague symptoms, a blood-based biomarker may be sufficient to remove the concern for pancreatic cancer and allow them to be discharged from follow-up. If it's a positive test, it may move them forward to imaging and move them along this kind of diagnostic cascade. In high-risk individuals, they're going to have follow-up regardless, but a blood-based biomarker may be able to accelerate their diagnostic process if it's positive and detect disease earlier, which is really one of the, is really the only way we think at this point to affect the survival of patients with pancreatic cancer. So early detection is really essential for trying to move the curve so that fewer people actually die from this horrible disease. People with imaging abnormalities, I think, also could benefit from a useful blood-based biomarker test, either accelerating their diagnostic process, moving them to either endoscopic ultrasound and a biopsy, or if the findings are negative, moving them back to clinical follow-up. And also individuals with worrisome symptoms, since there's no gold standard for the diagnosis of pancreatic cancer. A blood-based biomarker could be very useful in terms of accelerating or prioritizing their final diagnosis and moving them into effective therapy. I wanted to give you an idea of the current diagnostic landscape in terms of how different types of tests perform. As I mentioned previously, imaging is really the mainstay of the evaluation of pancreatic disease, and CT or computed tomography, magnetic resonance imaging or MRI, and endoscopic ultrasound, which I mentioned before, are really the mainstays of this evaluation. And endoscopic ultrasound is shown to the right of this image. These tests have different sensitivities and specificities. The specificity of CT is actually very poor, only 43%, somewhat better for MRI, and better still for endoscopic ultrasound, which is an invasive test as well. The sensitivity of these tests is a little bit better than the specificity, but still for CT and MRI is much less than 100%. Endoscopic ultrasound has much better sensitivity, as you would imagine, but again, it's a more invasive test. So these imaging studies leave a lot to be desired, really, in terms of their sensitivity and specificity. And this is the way that we feel that a blood-based biomarker could really contribute to this diagnostic process in terms of either directing individuals to more invasive procedures or moving them back along this diagnostic cascade if the concern is less. Also, for the more invasive tests, in this case, fine needle aspiration cytology, these tests are not perfect either. Although you can see here the sensitivity and specificity of these tests are rather good, they aren't perfect. And this is a situation where you're actually placing a needle into the substance of the pancreas and pulling out a sample of cytologic sample from the pancreas to evaluate it for cancer. But even in this situation, the negative predictive value of the test is relatively poor, only 75% for both of these approaches, either through the skin or through endoscopic ultrasound. And the reasons for this are probably multiple. One is that this pancreas is a very deep-seated organ, and it's difficult to target small lesions within it. So it's possible to simply technically miss the lesion. It's also possible that the cytologic sample that's obtained just may not be sufficiently robust to allow a specific diagnosis. So in this situation as well, we feel that a blood-based biomarker could be useful in terms of assisting in diagnosis. And really, it is putting all of these informations, all the information from these different types of testing together that really is the optimal way to lead to an efficient and accurate diagnosis in individuals suspected of having ductal pancreatic cancer. Particularly, I think that the blood-based biomarker can interact in this diagnostic process at multiple sites and in multiple types of clinical presentations. And I wanted to emphasize really the complexity of this process because the pancreas is a deep-seated organ and because the diagnostic tests available to us currently are all less than perfect. I hope this has clarified some of the issues in terms of pancreatic cancer diagnosis for you today, and I thank you for your attention.